session with a question to Sherrie, and also invite all of you to include in any of your answers any reflections on what Isabel Wilkerson or Vince Bonham and his lab said before, because I think it really set up this panel quite beautifully. So Sherrie, when we had our panel call, one of the things that really struck me, and I think it also struck Brendaly and Rachel, was the fact that that George Washington was sending people out into the world to help address and dismantle inequity and address by addressing social determinants of health. Mm-hmm. But there was no course that taught people how to go out and taught people what to do. And I'd like to ask you just sort of about your experience with that and how you set out to develop something that helped prepare people, didn't just as we talked about earlier, say there was a problem, but not teach people the history of the problem and how they could address it. And perhaps also add in a little bit about your community research work.
Oh, thank you so much, Gwen, and thank you for this opportunity to be a part of this panel. But first, let me say, after Isabel Wilkerson spoke, what was coming through my heart was hallelujah, hallelujah. You know, I've read her book. I certainly have her book here in my office. And it is, as Christine Wilson talked about, an important paradigm shift for many. But I think for many of us who have different identities, whether it's gender, persons of color, it just really resonated loud and clear, even though at times when we could not put a name to it, you know, all of the things that, you know, people in this country have suffered. But I think, as she pointed out in her comments earlier today, all of the historical atrocities that we have witnessed as a world and even in our country, especially the events of George Floyd, there was something different. That was a catalyst that I always say to my students, really, that was started by a piece of technology. As Dr. Vince Bonham talked about, the young woman who caught all of this on the cell phone, and how that piece of technology just implemented a groundswell, you know, of this paradigm shift. And I think that when we think about our workforce, you know, I'm just so honored that my faculty, my chair, also Dr. Lori Tiki, who is the director of our PhD program here at GW, wanted to start a course. You know, when you think about the workforce, our public health workforce should be our advocates. You know, we should be at the forefront of advocating, you know, for our patients, our colleagues, but we are starting to see a shift in the workforce. We have a declining public health workforce. You hear of nurses just leaving their positions. We certainly saw much of this with the COVID pandemic. And many national organizations, including nursing national organizations, also medical organizations, are really calling for us to look at our curriculums and how we train the public health workforce. And a centerpiece of that is the determinants of health. I go beyond social, and as I'm teaching our students here in nursing, because the determinants aren't just social, they're also economic, they're also environmental, and how these determinants of health are really important drivers for the disparities that we see. Another important thing we have to do is to educate our workforce, because we also have to look at who enters the workforce. How does the public health workforce, how is the public workforce educated and trained? And then also, which communities do they serve and practice, so that when we look at national data, we see these high incidents of disparities and chronic disease conditions, as well as mortality. Why do we see these pockets of disparities in certain communities? And that's because we don't have the workforce support, the funding and support that we need, across this country and even in the world. But in developing this course, one of the most important things I wanted students to leave the course with was understanding how these determinants of health are drivers. And I wanted them to also leave, Gwen, with a health equity lens. And one of the things that I challenged them to think about were questions. I started with questions. Who are the specific populations affected by a particular policy, practice, program, or decision? And what are the potential impacts on these populations? And then the other thing was I wanted them to put on their health equity lens and ask questions: in what ways does a particular policy, practice, or program ignore or worsen existing disparities and health inequities? And then the most important piece for me, because I really do believe that when you think about disparities and health equities, that it really looms large. It is a wicked problem with multiple layers, and there are many synergies between these layers. But how have we intentionally involved the specific population, which is why your organization, this organization, Gwen, is so important, because we help advocate for patients. We involve the patients in the decisions that are going to impact them. And let's talk about training. As a researcher, most of us are trained to not involve the communities at the beginning of our research. We may place our research in the community, but I think an important distinction for me, and that has really been a call to action for me as a researcher, is that I don't want to do research in the community. I want to do research with the community. And that's an important distinction. And I think that's really important, how we train the next public health workforce around the determinants of health. And then finally, I want to say, as again, Isabel Wilkerson pointed out, the language that we use and how we use it. If you look in the literature, you will see many references to disparities, health inequities, and health equity. Health equity. And many times you see that these words and terms are used interchangeably, but they're very different. And health disparity, of course, focuses on the disproportionate differences in health between people. Again, as Isabel Wilkerson challenged us to say, why do we see those differences? And then health inequity are the difference in population health status and mortality. But it's not just the differences, but it's the rates that are systematic, patterned, unfair, unjust, but also actionable. And then finally, health equity is what we are all striving to get to for all. And that is the fair and just distribution of all the social resources in our country. And I think we've heard many examples today from Ms. Wilkerson and also Dr. Bonham about how those resources are not equitable. And I think that that's one of the things in developing this course. I co-developed the course with another great colleague, Dr. Erin Athey, who is on the ground. I call her a foot soldier, helping to place nurses in some of these communities that need it most.
Great. Thank you, Sherrie. There's so many things that you talked about that just lead to so many other questions, and also so many linkages to what we will talk about on this panel. One of the things that struck me, I mean, and it's something we've known for a very long time, but I think the illustration that Ms. Wilkerson did was so vivid, was the difference in the health of the Nigerian man in his 90s and his son, Nigerian American son, in his 50s. And what are the structural and social, what are the structures and social aspects of his life that made him at high risk of I think he had high blood pressure. He had other chronic conditions that often come along with being a member of a historically marginalized group in this country. I think the other thing that I remember taking away, and also hearing from Katie Cueva, who's in Alaska, is one of the things that you mentioned, Sherrie, and I know it's incredibly, it's central to Brendaly's and Rachel's work, is to not do research on communities, but do research with communities. And Katie even talked about only doing research that she's invited in to do, Dr. Cueva, that she didn't just do research that was, she made sure that she wouldn't do research that were just answering questions she thought were important, that it really had to be patient driven. And Brendaly, I know I don't even know where to start with you, because I can start with either your badass community health worker, and I can also have the kind of connection to what you're doing with PCORI, and really truly trying to enact and embody patient-centered outcomes research rather than I don't even know rather than what, but patient-centered, where we really truly live what we say that we do, which is that the patient is the center of everything. So I think I'll ask you to start a little bit with the community health worker promotor aspect of your early and continuing engagement in advocacy, and what it meant for community healthcare workers to be both of the healthcare enterprise and of the community, and what difference that made in outcomes for the people that we serve.
Certainly. Thank you. Muy buenas tardes. Good afternoon, Gwen, fellow panelists and attendees. I really thank you for this opportunity to share, as you mentioned, some of these questions that we have been pondering. And indeed, I would like to share more on that intersectionality of the personal and professional experiences as part of my identity in the healthcare experience, no? Latina from Puerto Rico, first generation college graduate, bilingual, and I grew up being a Spanish speaker. And from that experience growing up there, my first encounter with a promotora was my auntie, my Titi Carmen, and many of us in our families, we do have that person that helps everybody else with their symptoms, following up with treatment, offering to go with you to the doctor, or deciphering the instructions, filling out paperwork, being moral support, and following through with adherence. And that experience really guided my advocacy work. I consider myself a CHW promotora advocate. It guided my work for 10 years at the leadership of the Florida Community Health Worker Coalition. And I did there a lot of the awareness and motivation to move forward the needle with the community health workers as a public health workforce in capacity building, not only for direct service delivery, that is probably the more traditional definition, but also more with the research and evaluation, and specifically patient-centered research. And I would like to share, it may be in the chat for the public or afterwards, there is a infographic that it really tells us what exactly are community health workers, these frontline public health workers. Let me see if I can do share that with attendees. And please confirm that you are seeing
Yes.
this infographic. And you may know them as promotores de salud, late health workers, late health advisors, peer mentors in many cases, navigators, community health representatives. And they're not necessarily defined by the training or license or credential. There's no national standards. There are many efforts to standardize some of this work and recommendations for those competencies, for those skills that are needed. But it does vary from state to state on how to interpret those standards and that guidance. And most of the efforts we have seen is about credentialing as a certificate and as kind of weighing in into the workforce and being recognized with having code of ethics and pathways. But let's remember that not all community health workers and promotoras are within that end of the spectrum. It's a continuum of experiences. And some promotores and community health workers feel very much that their best contribution is after church on Sunday, doing education, or knocking on somebody's door and offering help. So from that to the other end, there is a lot of variance within the identity of community health workers. But main definition includes that level of cultural, linguistic competence that is helping them bridge the healthcare system and the communities that are affected in their role as a connector. There are several important studies, either funded by PCORI and others, that do show how interventions by promotores and community health workers do improve health outcomes. And in doing so with those populations that are experiencing health inequity, is part of the arsenal to advance health equity and even reduce health costs, which is something that funders and payers are really looking at very closely. And not only on health as we know it, but well-being concepts that include the racial discrimination, employment, partner violence, food insecurity, and the like. And this infographic I will hopefully share with the public here from attendees, because it does have some links that you can pursue more of your knowledge of community health workers. Let me stop sharing. Stop share. Yes, I'm back. And that work with community health workers, that on the ground experience, it was not only with the research, but during COVID, I had the experience of being an executive director of a small non-for-profit near the Mexico-US border, where the community health workers and promotores were actually providing the food boxes, helping the transition from face-to-face interactions to online and telehealth, because they also had to learn for themselves how to deliver services in such an environment. And with that work of the promotoras, not only on direct service delivery, but also into research and capacity building, another dimension in the kaleidoscope of my identity in the healthcare experience, it actually is more of a personal, that guided my latest work with invisible disabilities, specifically hearing impairment. it took me 8 years after diagnosis for me to make a change and to act on that because of stigma, labeling, cultural, that even a highly educated person has to fend for and work through the system. And when do we choose to disclose that information to others when there is invisible, right, or less noticeable as part of our identities and within the healthcare system? And I want to link this to that previously discussed topic of discomfort, because it does play a big part in your decision-making process about how do you attach, what label do you attach to yourself, how do you prioritize, make priorities in terms of your identity and who you are and what you bring to the table. And part of me handling that discomfort with my own diagnosis was to put it to work. And I joined a team to do a proposal on engagement and creating a Hispanic hearing a coalition, because that spanned through 3 states in Florida, Arizona, and California. That's how I was able to handle it and be more comfortable with the discomfort of my own impediment and feeling that I could contribute beyond the individual, but rather to our community. And I think that part of inclusion also is very much in the mind of the organization that I work with, that you and I, Gwen, and I have been associated with for some years, and is with the work of PCORI and the engagement rubric, those engagement principles for equity and inclusion. And I also provided 2 links that hopefully the public can explore more. These are 2 documents that provide that set of guiding principles for placing diversity, equity, and inclusion at the center of those health research partnerships. And they were developed with the PEAP, the Patient Engagement Advisory Panel, and those 4 principles of inclusion, equitable partnerships, trust and trustworthiness, and accountability, actionability. Those are offered in more fleshed out way, so we can have these kind of conversations from the start with the explicit goals of partnership and how do we do those partnerships. Those documents could help any person or organization involved in the research community. And we're very excited at PCORI with this current work, because we are now updating that engagement rubric that years back Gwen and I were part of, and with input from many stakeholders along the way, in interviews, focus groups, town halls, and now in December, a little bit more concrete work to move from data to evidence. Because we know that, engagement does work, but how? How do we do it? What guidance can we provide organizations to work together in real partnerships in truly engagement and the impact, and for who? Who defines what's meaningful research, and what? And for that work is the science of engagement. So we're currently at PCORI working. I'm very excited about those 2 initiatives on the update of the engagement rubric and the moving from data to evidence through the Science of Engagement Awards.
Great. Thank you, Brendaly. And I also, I think about this idea of invisible disabilities, whether they are short-term or long-term. And as a cancer survivor, 3-time cancer survivor, that was one of the things that that happened throughout my breast cancer diagnosis. But you look so healthy, but you look like you're fine. And I was and I wasn't. And we don't all choose, we live in a very multifaceted world, and we all have very multifaceted identities. And I think that that's something that we're often asked to choose one thing. It's just like you choose on a multiple choice. Well, I want everything. I I want all of my identities. I want all of the things that I want to be able to be more than just one thing. And I think everybody wants to, I think we all aspire to be more than one thing. I was also thinking about about one of the things that our friend and colleague Denise Smith said on a podcast that we did a while ago, where she was talking about community health workers, and she was talking about an experience with a patient at a major institution, which is pretty progressive in terms of using community health workers and feeling welcoming. But the doctor, the patient was going home, and the doctor prescribed a breathing machine. And the community and the patient took it. The patient took the prescription, didn't say anything to the doctor. And when she was being checked, when she was doing her transition plan with the community health worker, she told the community health worker that she had no electricity in her house. But she was ashamed of saying that to her doctor. So actually working on the ground with communities and and looking at them as whole people, as we talked about earlier, is so critical to achieving health equity and achieving social justice for everyone, health justice for everyone. So Rachel, again, I've got about 17 questions that I want to ask you. I want to continue our ongoing conversation, but one of the themes throughout today has been around narrative, and the other theme has been around narrative and evidence, and what our system was built on. As Vince said, the genetics and genomics scientific enterprise was built on principles that are racist in terms of genetic identity. And you've done so much work as a social scientist, as a sociologist, and as an active patient advocate in eliciting narratives from patients about their experiences and using them in many, many different ways. There's so many multifaceted ways that the patient experience work that you've done and health experiences work that you've done can really is for everyone who's engaged in helping to ensure that there's healthcare for all and understanding what patients experience through their healthcare paths. So could you talk a little bit about your work in Health Experiences USA, and then I also want to talk to you a little bit about your trust work as well.
Yeah, I'm very happy to and glad to be here with all of you. I was listening to both of you, Sherrie and Brendaly, over the last little while, talking about the importance of doing with rather than doing in the community, and thinking about how powerful that is, and how in addition to that, I've come to think about my work as a action researcher and as a scientist in the social science domain as really being focused on learning from people rather than about them. I think that our scientific enterprise has been very oriented towards objectification. I am an expert and I am going to learn about other people and then come to my conclusions. And that when we start out instead from an intention to learn from the people who participate in research, who trust the enterprise enough to give it their time and attention, enough to share their very private stories and experiences, I think it puts us a little more right-footed. I loved Vince and his lab's quotation from the book cast that we heard talked about today. And I just want to read again this little piece, which I just took a photo of when Vince was showing it. Radical empathy means putting in the work to educate oneself and to listen with a humble heart, to understand another's experience from their perspective, not as we imagine we would feel. I think the qualitative enterprise and research is very well poised to do that and to combine it with rigor in a way that offers some specific evidence producing advantages. I think people should speak in all kinds of forums. They don't need researchers to do it. The advocate in me is, all about our little d democracy, where people are fully entitled to speak for themselves and empowered to do so. But I also think that the research enterprise, which has some advantages like systematic sampling and rigorous analysis, and can embed, as Vince as well as others on this panel have been demonstrating all day, can really embed an ethos of equity into the design of how people's voices are collectively represented, and the opportunities that others have to hear those voices is enriched by that ethos. So that's what I think our scientific enterprise can do. And I am an unabashed advocate for patients, for families, communities, and equity, and also for the qualitative enterprise in the research paradigm, because I think it offers us that opportunity to open up empathically in the way that quote, which has now probably been iterated at least 3 times in this one policy forum, suggests we all need. As far as evidence goes, I think just adding to what others today have said, I do think that having some standards around evidence is really important, so that our decision making isn't sort of swayed by anecdotal accounts, by narratives that people may be positioned to put in front of the most audiences, and they just sort of gain the most traction. I think evidence is a little bit more painstakingly accrued little by little, and it should be co-created absolutely 100% with communities who scientists are learning from and alongside the whole time. I don't know how to put anything in the chat, but the www.healthexperiencesUSA.org website is one place to maybe take a look at where we are doing narrative work using maximum variation sampling, trying to talk to the most diverse people, groups of people possible about their experiences with health and healthcare, and then share via video clips and audio clips what we have learned from those interviews when they've been rigorously analyzed. So the site is just growing. We have hats off to 14 countries around the world who are doing work using the same method and have done hundreds and hundreds of projects like that. We are just starting out, but we have some work on breast cancer and on inherited cancer risk that both Gwen and Vince were able to contribute to. We just put up a module on experiences being in clinical trials from the point of view of people who are in them or who may decide not to be in them. And we have some work as well on depression and on traumatic brain injury, and a lot more coming. So take a look if you feel like it, and get in touch with me to let me know what you think and how we can keep doing this better and learning from all of you.
Great. Thank you, Rachel. And Ashley put the link to the site in the chat. I love your framing of learning from, not about people. And I think that was distilled down so much of what we talked about today. It is about putting people in the center, not putting power in the center. And I think that is something that we've been talking about through many of through our work for years and years and years. The other thing that I wanted to ask Sherrie is, when earlier I said, I want multiple identities. We all want to be seen as more than just one dimension. And one of the things we had a conversation about was how in your personal interactions with the healthcare system, as well as some of your professional interactions, you were seen in one dimension. You were seen as a Black woman, and that your identity as a Black woman absolutely dictated and controlled in many ways your experiences. And I wonder if you would comment, if you would share a little bit about that and comment about that.
And thank you, Gwen. I've seen that from many different perspectives. I've seen it over the years with my family. My mom has given me permission to share her story. She suffered from years from chronic hypertension, which ultimately caused her to have kidney failure. I just remember, just as Isabel Wilkerson talked about the trials she went through with getting certain people to pay attention to things with her dad, I saw that with my mom. But it hit me front and center when the focus became upon me. I remember I was a postdoc, and I went in for my annual physical, and they found like a little cyst, and my gynecologist wanted me to go have an ultrasound just to have it checked out. And I remember how they put you in the room, you have on that little robe, which is so unattractive, and you sit and wait and wait and wait until finally the doctor comes in. He never made eye contact. He never said, hello, how are you? He never asked me how I would like to be addressed or referred to. He just immediately, in the worst tone and tenor, began to ask me a lot of personal questions with the underlying assumption that because I'm a Black woman, I have multiple sexual partners, start talking about sexually transmitted diseases like AIDS. And I was totally wounded and taken aback and horrified. And so what I did was I made that decision. I'm not going to accept this kind of treatment. I got up in that little robe and I just walked out. And he said, excuse me, where are you going? And I said, I'm leaving here today. And I proceeded to tell the nurse about my experience. And then I also, filed a complaint. And so that's the assumption that people have when they see individuals of a certain identity. We make certain assumptions. And I do want to say that my story, I've heard it over and over again with women, especially with some of the breast cancer work I do, how some women, when they go in for a mammogram, they are just offended, because they may be a certain size or whatever. And I think this is where I go back to the conversations about how we train our workforce, our public health workforce, how we have to have radical empathy. But even as Isabel Wilkerson talked about, we're all humans, let's find that common ground. But she calls it radical empathy, but just on a basic level, can we not be kind to people? Where has the kindness gone? We just wound people in our conversations and these assumptions that we make about people's certain identity, if they look a certain way, if they're a certain race, ethnicity. Also, people have really just said, the most wounding things, if you have even persons with accents, I remember someone said to me, I'm from the South, North Carolina, grew up in a rural town, and a person said to me, people from the South have to be really careful because of their accent. People think that they're not really smart. How condescending is that? And so we see these kinds of examples, throughout, our healthcare systems. And this is where I say people have to be courageous. These are sometimes difficult things to confront because we don't, Gwen, often hold the power. But we each as an individual and for our families, we have to make a decision that no, we're not going to, accept that. And I think now healthcare organizations are putting in place, I know many hospitals have ombudspersons, there are patient satisfaction things. So we have to take that action, to make sure that we don't experience those kinds of things. And the other thing I think that we all can do is we have to become a part of organizations like this. We have to get on these boards, where we often don't see much diversity, so that we have diversity in the decision-making opportunities. That's what I would say.
If I may piggyback on Sherrie's point about getting involved, I strongly applaud that call for action and invite the public if they think that they can contribute that way. Just explore the possibilities, like with PCORI at pcori.org. We have volunteer ambassadors. That's how I started in 2013. And with a brief training, it's just kind of going over some basics of what PCORI is, what PCORI, patient-centered research really is, and also opportunities to be a merit reviewer for those funded projects that move forward. So you can have a say as a patient, as an expert on your community, as a stakeholder partner. Your decision, you are part of the decision-making process, evaluating those applications for research. And of course, like Gwen and I went and became members of advisory panels. They are not only the patient engagement one, but there are several others that you can explore and see the fit, and applications are due on March 31st.
Great. Thank you, Brendaly. And I think, it is, there are absolutely places where patients, family members, we're all patients, we're all family members, can participate. I think what the evolution has to go beyond just participating and for this to be received. And for people to do what, like Rachel said, which is to learn from the families, from the communities, from patients, from people or species, as Isabel Wilkerson said, and not simply about. And I wanted to just transition to something Rachel talked about. Rachel's been doing work on trust and trustworthiness for a while. She did she really wrote this great paper that we published. I was honored to be a co-author on how we turned the trust. Everybody would talk about how we could make patients trust the healthcare system, and we talked about how can we make the healthcare system trust patients. And Rachel's been doing new work on trust, and I would love to hear you talk more about that and where you're going, because it is true. Our full lives and our full selves are rarely seen in our healthcare encounters, which make up such a small part of our clinical encounters. It make up such a small part of our daily lives and our health.
They do indeed, but they have a big impact. And Sherrie, I was listening to you talking about this. You're a strong, beautiful, accomplished woman, right? And yet all of us, we feel so vulnerable when we're in that situation, and it's very memorable. So yeah, I think trust is a big buzzword out in the health services research community now. And there is a lot of focus both on how to get patients and families to trust healthcare more, and on institutional trust, which I think is an important topic. But turning the lens so we think about things like why clinicians should be trusting their patients and how important that is, and how can we make sure that we're supporting the growth of people's trust in themselves rather than having a paradigm that's about giving your trust to someone else. I think self-trust is such a strong predicate for a healthy and happy life. And I think in healthcare, particularly for people who have chronic conditions and have a lot of time to experiment and tinker and learn about their own bodies and how their lives and their chronic condition intersect, and what they care about and what works and what makes them feel good and what doesn't make them feel good, and how the time of day matters, and how when you take different medications and different orders matters, and how your spiritual life, your emotional life, your self-care, all of these things. We just did, as part of a special issue for the Hastings Center report, some of the lead editors had done a run-up and done a systematic review of 50 years of published work on trust in the peer-reviewed literature. And self-trust wasn't even a category in the review at all. And so I've gotten really interested in what narratives have to say about self-trust. Sherrie, again, just really resonating with your story. You didn't really talk about it necessarily undermining your own trust. It certainly undermined your dignity. But I think a lot of times people come out of healthcare encounters with their self-trust undermined rather than bolstered. And I think the question is, how can clinicians and the healthcare system and everyone who's on these clinical teams be on the patient's team by helping them learn to trust themselves better? In my Department of Family Medicine, my chair often says we should be asking people, what do you want your help for? And I'm suggesting that we add a question to that, especially for people who are coping with health issues on a daily basis. What are you doing at home that's working for you? So we can learn from that, and we can build on that, and we can bolster that. It is very different from self-management, which I think is often implemented in clinical settings, but is more about perhaps exporting what clinicians think needs to be a priority for folks with chronic conditions, then learning what their priorities are and how the clinical team can support that.
Yeah, great. I mean, that's so perfect. And when we, the video that comes at the conclusion of this, at our conclusion of our panel, which unfortunately is coming relatively soon, it's a story, a woman telling her story, and a lot of it is about her self-trust being undermined as she went through the healthcare system, and she is a healthcare provider herself. I saw that Sherrie was looking at something, writing down, thinking, I could tell, as Rachel was speaking. And we, in these last couple of minutes, I'd like to just, we've talked about this as being not just, we talked about, first of all, really telling the truth about our history, talking about the steps and the paths to achieving health equity. But I want to finish with what you think health equity looks like, and what you think, and also feel free to add something else. But what would a just and equitable system look like? and what are things that we might be able to do to get there. And Sherrie, I'll start with you. I saw you made some notes and you may have something you want to add to Rachel's, but we've got about 3 more minutes in this panel. So
Oh, I know we're having such a good time, and but I wanted to say to Rachel and how important her work is on trust. And the reason that resonated with me is this construct of self-trust. You know, it has been there's just a paucity of data on that. But what you hear is also part of the messaging and the communication, because you always hear the community doesn't trust us. So I push back and I say, because the health organizations have given the community so many reasons not to trust them, that how can the health organizations become trustworthy? That's another question that health organizations and the workforce, we need to be asking, how can we become more trustworthy? And so when I think about health equity, I think about that everyone, individual, has access to the resources that are working for them, Rachel, that they have access to those things that will help them be their healthiest, best selves. There's food security, not food insecurity. They have access to what they need. They don't have to worry about huge copays. They can't be turned down because the first time they enter a hospital or clinic, what insurance do you have? That's the first question. Sometimes people don't even get asked, how are you doing? The first question they're asked is, what insurance do you have? So that's what I would say health equity looks like. And how we get there is by working together and putting, as Isabel Wilkerson said, let's start saying we instead of saying you, and it's not just I, but it's we.
great. Thank you, Sherrie. Brendaly.
I echo what was said, but also to add from the generation, from the angle of generation of new knowledge, that is a system that is integrated, that we are able to provide the best information for people to make the decisions about healthcare that are relevant to them and applicable to their situation.
Great, thank you. And Rachel, I'll give you the last word.
I'll just be really quick and iterating what our friend and colleague Meg Gaines often repeats, which is that every system is perfectly designed to get the result that it gets. Our system produces inequitable outcomes and disparities. And so if we do not change the system, we will not be changing the results.
Great, thank you. And I think it was also, I mean, when Chris Wilson was talking with Isabel Wilkerson about what persists in textbooks, what persists in EHRs, how we don't, I mean, there are so many places that we can start, and all of them will make an impact. I want to thank you all so much, Sherrie, Brendaly, Rachel. This has been a really such a thought-provoking and also I would say really warm and open panel, and I'm just so thrilled to be in conversation with the 3 of you. I wish we could go on for a lot longer. I know we could, but we will continue this conversation in one format or another. We'll also share some of the resources. We've shared some of the resources in the chat for attendees, and we'll send out things post with our thank you notes to our attendees.